Dear colleagues, good afternoon. We are happy to have you here today on our international joint session on cardiovascular pathology. So first of all, I would like to say that it is a great pleasure for us to perform this session here on this Congress, and I personally thank Irina Lapina for the idea to have such session in the field of this Congress. So we're happy to hear to present. And my name is Zalina Kudzoeva. I am a cardiologist from the Center, Bakulev Center for Cardiovascular Surgery. I would like to present you my co-chair, Dr. Kristina Sanina from New York, Montefiore Medical Center. Kristina.
Hi, good afternoon. Thank you for having me. I want to thank Bakulev Center and this conference for the invitations. And I want to also thank all the doctors who's going to be presenting today. This is Dr. Pedro Villablanca, this is Dr. Eugene Kalenic, Dr. Miguel Alvarez, and Dr. Jorge Romero. Thank you very much.
Thank you, Kristina. We have very wonderful presenters today. I hope the session will be interesting. So let's start. And the first presentation will be from Dr. Villablanca from USA, Detroit. And the theme of the presentation is Update on Interventional Therapies for Structural Heart Diseases, Aortic Valve, mitral valve, and tricuspid valve. Please.
Thank you very much for having me here. Thanks, Kristina and Selena, for the invitation. Let me share my screen. Let me know if you can see it. Can you see my screen?
Yes.
Perfect.
Yes.
Yes, there. That's good. Okay, so I know we have like 15 or 20 minutes to talk about this huge topic, so I'll try to go a little quicker to cover it. It's a lot of information, but I'll give like an update with perspective on the structural work for aortic, mitral, and tricuspid valve. So this is a little bit just to give you a background how procedures have increased in the structural world in the last almost 10 years. We saw from above 100,000, they're going to go close to 500,000 per year. That's the prediction in a couple of years. So I think there's a huge growing potential for this field. I'm going to start with the aortic stenosis. This is a classic slide where they tell you pretty much we're living more, we're getting older, so aortic stenosis prevalence is going higher and higher. And a lot of these patients are asymptomatic. Some of them are in the moderate range or severe range, and we have to follow them carefully and give them the options that we have. And as we all are aware, most of the patients with aortic stenosis are within the low to moderate risk, and the high risk inoperables were the list of the patients at the early trials. And why is this such an innovative technology? I would say because it's so simple, looks like a stent, like the coronary balloons. It comes with a stent, a balloon, and you can easily implant it, at least the balloon expandable as well as a self-expandable. We all are aware of the trials, either for the SAPIEN valve. I'm going to comment more on the US trials, the SAPIEN valves, the balloon expandable for going from inoperable to low risk, and the same for the self-expanding with excellent results. Some of them same as surgery, and so far it's sort of durability. We have data now that they're even better maybe than surgical valves. And so far, where are we with the guidelines? Still TAVR, it is considered 1A for high or prohibited risk surgical patients, but it's not considered a gold standard for low surgical intermediate risk. Is only like 2A. And I'm going to give my perspective and updates on this. So far, we've covered all the risk, and now what's pending for TAVR, even surgery to address asymptomatic patients, moderate AS. So, I always talk to my fellows when we talk about aortic stenosis, and people say, oh, this is not severe. The velocities are under 4 of the areas. above 1. And aortic stenosis is not a black and white phenomenon. It's not like you have above or below those numbers and you're going to be severe or not severe. I would say every patient is different. You have to put into account the EF, the LV thickness, the myocardium, the amount of fibrosis. And there's more and more data that patients with criteria for moderate AS have similar cumulative survival, not similar, but like not very good survival as compared to mild and AC and no AS patients. And I think this is where also the field is moving now, treating early patients, not just with the criteria that we have now for severe, also moderate. I think this is likely also maybe a misclassification that they did 20 years ago when they used these fixed parameters to define what is severe or not. I think we had to go beyond that to define when patient needs therapy. And this is a nice graph I took from one of the TCT presentation. There's a lot of variability, not because your area is above 1 doesn't mean that you're not going to have adverse events. You can't tell a patient, no, you're 1.5 or 1.3, you shouldn't be having symptoms. Everyone is different. Everyone can manifest at different stages, and I think that's where the TAVR world is heading now, treating more earlier, either moderate or asymptomatic patients. So what's going on, at least in the US and Europe, we have the early TAVR where patients that are truly asymptomatic, meaning they already passed a treadmill test, they've been randomized for TAVR treatment versus watch and wait. We've been part of that trial. I think the trial's already started recruiting, and we should be seeing results in the next couple of years. And I think that's one of the big moves that we're heading with TAVR, not just waiting for symptoms, just treating when we catch them. And one of the other things that we're going to be seeing is like patients with moderate AS and heart failure as well, where you don't have the criteria for severe, but you have moderate and you have heart failure. Those patients, they have a weaker heart. You can't have the same criteria, expect to have the same criteria to think they're going to have symptoms. And I think that's the other trial that might change some of the paradigms of intervention in aortic. And here we have early data from surgical trials about early AVR versus watch and wait. And we already see that and this is surgical data, but I think we'll mimic the TAVR results will be mimicking this. The earlier we treat these patients, the better for them in terms of outcomes. A little bit about TAVR and embolic protection. I know that the data is not as significant as we could expect. At least in the US, we have only the Sentinel. There are more trials that only covers the right carotid and the left carotid. There are more trials that are coming with new embolic protection devices for TAVR that might cover the whole spectrum, the whole arch. And that's something that we might see in the future. Of course, we need to see the data behind that, but I think it's coming. What about aortic valve and bicuspid? I think bicuspid, depending on the center, has been seen only as a surgical option. And at least in our center, we analyze the patient, the anatomy, but bicuspid valve is treated as a regular tricuspid valve nowadays. I think the TAVR results for bicuspids are spectacular. You get a great sealing, and we have data from TVT. We're soon going to publish some data locally from Michigan, showing really good results for bicuspid. But we know that the results are pretty good, similar to tricuspid. Of course, TAVR is not perfect. We have to be aware of halt of thrombotic phenomena. That's why when you're doing these procedures, you have to follow them and be aware that this can happen. Also can happen with surgery, but patients should be aware of this. It seems anticoagulation work for this to reverse the process, but it's something that we have to be aware. Other therapies for aortic valve, this technology that, I haven't seen it, but I think it could be promising. You avoid the valve replacement. It kind of, those who are familiarized with the shockwave, you kind of break the calcium and make that leaflet that is restricted much more pliable and avoid the need for replacement. Is that going to be established therapy? Patients would like to be replaced, or just try this. What's the stroke rate? We don't know, but I think this is something that is coming. What about AI? There's this valve. It's already, the early results were shown from Europe. It's called the Jena valve. It's transfemoral. It seems has pretty good results for AI cases. In my opinion, I don't see this just for AI. I see it in patients with low coronary implant, where if you put a TAVR valve, you could include the coronaries. I think this valve will have this role, and it's coming. We're part of the trial here in the US, and I think it has a role in the future, not only in AI but also in some AS patients. So this was surgery, I would say, when surgery started in 1960 till 2002, from when the first TAVR was performed. And maybe this is what we're seeing now, TAVR in 2021 or 2022, with TAVR taking predominant lead. Is this going to be the future? Maybe in 20, 30 years, when everyone gets maybe TAVR as a first option, once the technology is evolving, sheets are smaller, better profile, better coronary access, maybe. Just put this as maybe just to have fun a little bit. Okay, let's move to mitral valve. Mitral valve is different than TAVR. TAVR is mainly a tube where you can easily fit a couple of valves. Mitral valve is completely different, different physiology, different anatomy. All the mitrals are different, so we can't mimic what we do in TAVR. And the options that we have to treat the mitral is pretty much at the level of the annuloplasty, chordae, or leaflet. And based on how the valve fails, these are the options that will come, and some of them are established to treat the mitral. So it's very important that you understand the mechanism of failure, because that will determine how you will treat. And this is where the trials and the new technology are focusing. What do we have now for degenerative valve? We have the mitral clip only for high risk, nothing for moderate or low risk. Some trials are coming for that. We have the cords, also some trials coming, preferably in patients with P2 prolapse for functional. We still have the mitral clip in patients with favorable anatomy and with optimal medical therapy, and the cardiovascular. And I just mentioned, mitral clip has evolved so much since the first case to the last co-op trial, and pretty much, if I can summarize the updates on mitral clip, it was a single clip. You had to grasp both leaflets at the same time, much less maneuverability. Now you can do independent grasping. It's much easier. I would say a third, if not half, of the patients that we could treat with a mitral clip, now most of them we can treat them. Of course, some of them are not ideal for the technology, but with the G4 technology and independent grasping, I think we were able to include a lot of those patients. This is an example where initially Barlow's valves were not meant for mitral clip. No one would have tried to attend clip to them, and now all these patients with Barlow's, we've done pretty good amount of cases with great results with the new technology. So I think that in terms of, like, though the mitral clip is not new, having the G4 is giving us options to treat prior pathologies or morphologies of mitral valve that were not a candidate. What else? Cardiogenic shock is becoming a great option in the transcatheter. We've done several shock cases with papillary rupture, muscle rupture, post-MI in patients who are not surgical candidate. And now I think with the transcatheter, it is having a great role here, and not just as a definitive therapy, also as a transition either to surgery or a more definitive therapy. What about other technologies? Okay, the Pascal is similar to the clip, meaning it's a grasping device, but has different modalities. Instead of when you remove a mitral clip from the LV because you don't like it, you have to invert the clip here. You just elongate, so you have less risk of interacting with the chordae or rupturing. Supposedly, given the design, you get less gradients. So we'll see. We're part of the trials. We're screening it. I would say we'll see these results in the next 5 years for functional primary MR. But this is one of the things we're having for repair. This is a case we did Ford for severe MR was a primary MR, and you see the results are pretty good. I would say similar to the mitral clip, in my opinion. What about the chordal repair? The neocord that initially was transapical, they moved to transfemoral. Hopefully we'll see this device coming. Is in Europe already being used for the early feasibility. In US, it will come soon, I would say. What's the beauty about the chordal repair? That you don't worry much about gradients. You don't surgery will be still an option or replaced with transcatheter because you're just replacing the chorda. You're not pretty much interacting much with the leaflets. So, and it's more physiological. Annuloplasty, we have two types: indirect, where you don't work through the annular plane. You just kind of stretch the indirectly the annular plane to lower the MR. There are different devices. Some of them, the NIH people, they work with the transcatheter with laceration. We'll see that coming soon. And there are dedicated devices, the Cardiovascular that we have available in the US as a trial. And then we have direct annuloplasty, where you just cinch the annular plane and you make it smaller, like surgery. Okay, I think one of the valves that will have a great role is the millipede device that comes with their own eyes device, so you'll be able to see directly what you're doing, and also then you have the possibility to anchor new valves. And this is what we've done. It's not an update, but this is what we do nowadays. What we have with the SAPIEN valves, valve in valve, valve in ring, valve in mag. This is not a new technology. I think it has been there already for like 10 years, but this is what we have in terms of replacement from valve in valve, valve in ring, and valve in mag. So where are we now for replacement for mitral valve? We have like 1,000 of options. And I would say there's several trials in Europe, in the US, that are trying this technology. I'm going to show the experience that we have here in the US. And one of the problems also when we do replacement is that you can have LVOT obstruction. If that's the case, the first option before to mitigate that was alcohol ablation. Then Lampoon came to avoid that, where you just lacerate the leaflet. This is the case we did at our hospital. And there's new technology now to create a myotomy of the myocardium instead of doing these more complex procedures that it seems is having great results with the early experience in animals and some humans. And options for replacement, I think we have tendon is having pretty good results now. I think it's gonna come to stay long time. I don't know, maybe short time. The main issue of tendon is transapical. I would say it's a surgical procedure. Anything that is transapical to me is surgical, though it's a catheter valve. It seems to work great for MR, especially in patients with MAC. This is a case we did at Henry Ford. And then this is what technology will really fly here, the transseptal technology, where you don't get any surgical access. This is the Edwards SAPIEN M3, where it has a dog and a valve that it has a much bigger skirt. So pretty much you go transseptally, you implant the dog here, and then you put the valve inside the dog. This is a case you can see with the Henry Ford, where you could see the dog being deployed, and once you have the dog, you inflate the valve, and you get great results. And this is just a summary. You'll be able to see it, when to consider one or the other. I'm going to skip it because of the time. And if we thought that tricuspid was complex, mitral tricuspid is even more. You have to consider the same scenarios: the leaflet coaptation, the annular dilatation, the IVC angle, the SVC angle, primary pulmonary pathology, and based on those, you'll have to pick what you can do. Of course, we still have this when surgeons already touch the patient. It makes us a favor. This is a valve in valve tricuspid. We do it from the neck and before, where there's no need to do anything new. There's already an anchoring that is a valve. So this is already established therapy that is coming to stay, because this patient will have a valve or will have a ring. However, in patients with native valves that has a problem, I think this is where we're focusing. Is similar to the mitral, meaning we will have options with repair or replacement, or in patients where you can repair or replace because of trial exclusion, or they don't have the anatomy, or they have primary pulmonary hypertension, for example, we can put valves here in the IVC. At Henry Ford, we have the Evoke valve. Is a transfemoral vein system. I would say it's worked great. I think we're seeing great results. Here you can see a patient with severe TR going into the hepatic veins after we put the valve. The TR has gone away. It's trivial and it's slightly related to the pigtail here. So, these patients, they can go home next day or in 2 days, meaning I think this technology is great and it's coming to stay. What about repair? We were part of the trial for the Pascal repair, the TriClip. The data was just published with great results of the TriClip recently. Again, transfemoral, I think, is going to be a great tool to have. The Pascal also enrolling for similar purposes. Not every patient can be repaired. You need to have a good coaptation gap. If your annular plane is dilated, I think those patients will not do well. The free wall of the RV will keep dilating, and maybe you will have TR even if you grasp initially. So I think every patient will have to be selected based on the anatomy, but these are the two options that we'll see soon available commercially in the US and Europe and the rest of the world. What about when you can repair or replace? So we have the CAVI option where you put an heterotopic valve in the IVC. There's a couple of companies trying either the SVC and the IVC. We don't have this trial, but we have been doing CAVI for a while, Henry Ford. This kind of CAVI that we do is pretty much like a rural thing that we do. We put a stent in the IVC and then we put a sapien valve. And you could see here, compare the first image to the other, where the congestion of the liver and the lower extremity is much better after you put the valve. There's a dedicated device now from Edwards for this that it's much simpler than what you're seeing here, that it incorporates the stent and the valve as a unit. So hopefully in the next few years, you will see these results. And I always put this is one of my patients. What do you see here? Where is the future going for mitral, tricuspid, and aortic valve? This is a patient of mine which you can see has had several interventions from Watchman and sapien valve, Evolute, a mitral clip, an Evoque, and ASD. And I think that this is where we're going in of course, high-risk patients, intermediate, and maybe in the future, all patients will have option to these devices, and there will be no need for surgery if the anatomy of the patient qualifies. And that's it. Hopefully I was on time here.
Thank you very much. Yes, we are on time. I just want to comment that the last one presentation, we will not have the last one presentation, so we will have some more time to discuss. Maybe some questions from the audience. Thank you very much. Very, brilliant presentation covering all, novel techniques in the field of valve procedures. And I think it is supposed to be very, very interesting for cardiac surgeons. Are they here maybe from audience? Maybe some questions? Okay, thank you. I just wanted to ask you regarding, we all understand that nowadays the paradigm, is moving toward transcatheter procedures, and the indications for transcatheter procedures is expanding, as you showed us, in different types of valve pathology, aortic, mitral, tricuspid. Brilliant presentation. I was really very interested in it. But my question is, when we select the right patient for the right type of approach, surgical or transcatheter, so it is supposed that a real multidisciplinary heart team process should be really introduced in all clinic. What is the status in your clinic, for example? Is really every patient with valve pathology undergoes multidisciplinary team
evaluation
approach?
Yeah, no, that's a great question. I think the heart team it's out of question. Like, everyone should be part of a heart team. There's no patient that we don't discuss with a heart team. Not just in the US and Europe is different. I think in Europe you can have TAVR without the surgical assessment maybe, but I do think everyone should be seen by a surgeon and an interventionalist, and the whole cardiology team And to give the perspective, because transcatheter options can go south, and you might need salvatages, and you need to see the surgeon to know you, to see what are the options. And the opposite too, if the surgery goes wrong and you can do a salvage with transcatheter. But the fact that some surgeons are not experts in transcatheter, and we are the experts, or you have surgeons that are hybrid, I think having all of them in a team, it gives you a better perspective. I think also it's been more and more data now in hybrid procedures where, for example, with a case which has a severe TR and severe AS, and it was too high risk for surgery for dual valve. But maybe if you do a TAVR, where instead of having a huge clamp procedure, you can do a TAVR replacement, and those patients we were talking, maybe you can get a tricuspid repair that is much more minimally invasive, right thoracotomy. There's no need for prolonged surgery. So I think having a hard team, is essential, and it's here forever. I mean, I don't think it should be taken away.
Thank you. Yes, because the main is a lifelong management for individual patient. Thank you very much, Christina.
Yeah, thank you so much. I do have a question. Actually, I have a question about this new IVC and SVC valves. Do they require anticoagulation, or you just give them high dose aspirin, or what's happening with like right heart and anticoagulation and aspirin?
Right. I think the field in the mitral and the tricuspid valve has been moving to give anticoagulation to all of them if you can, because those are low flow state chambers. So we like to put them on anticoagulation. Actually, the trials, if you can't tolerate anticoagulation, you're less likely to be enrolled. Maybe it will be an exclusion criteria. So yes, most of those patients ideally should stay on anticoagulation. We've had patients that, of course, they were put on anticoagulation and they couldn't tolerate it. One of the patients had to put a watchman, and if that's the case, then you have to go and follow the patient closely. Of course, there's more risk, I would say, to get thrombosis of the valve, early degeneration, because it's such a low flow compared to the left side that they might clot early. But we haven't seen that actually with the mitral valves, at least from the trial perspective, or even for the commercial cases. But I think if you can give anticoagulation, it's better. I think as we've seen in some TAVRs, I'm not sure in TAVRs there's data showing that it gives you more durability, but if you see early thrombosis, it could treat it with good results. But again, yes, anticoagulation is better. Is mandatory? No.
Okay, thank you so much.
Yeah.
And what about patients with concomitant coronary pathology, for example, who need to take another one, antithrombotic agents?
Right. So to me, I think this is, I don't want to, it's a great discussion. For example, if I have someone with CAD and they need aspirin or Plavix and anticoagulation, unless it's a fresh stent, I would just give them anticoagulation and one of the agents. If someone has had a bypass, and I do believe that having them on anticoagulation, if they have a high bleeding profile, I just put them on a single anticoagulation and keep high dose statins and follow. Meaning every patient is different, but if you just had a fresh stent, I would just put you on aspirin or Plavix with the anticoagulant. I maybe keep that for 6 months. I think this is like the surgical valve. When you do a mitral surgical, you put them on aspirin, keep them 3 months ideal in anticoagulation, and then you can follow those patients and maybe drop the anticoagulant, give the aspirin. I think every patient will be different. I think what I would follow first is standard, but of course you can modify it based on patient necessity and patient characteristic and medical history.
Thank you very much. As you mentioned, we have a lot of what to discuss in future, I hope, sessions. Thank you very much. It was a great pleasure to have you. So we're going to the next one presentation, and the next one will be Eugen Kalinici from Moldova, and the theme of presentation is update on invasive treatment of multivesicular coronary artery disease, percutaneous coronary interventions versus coronary artery bypass surgery.
See guidelines on myocardial revascularization. I guess in Russia it's also these kind of guidelines. And in 2021, we have ACC SKY guidelines for coronary revascularization. What did influence the outcome, and what did we see in guidelines before? Because now we have some new data concerning myocardial revascularization. So these are the guidelines that were issued in 2018 concerning that the 3-vessel disease with low syntax score, it's below 22. It favors CABG as well as PCI. 3-vessel disease with intermediate or high syntax score, it favors CABG. We have some new guidelines issued in 2021, but we will talk a bit later about this. What studies did we have until 2018? It was syntax study. It was taking into consideration the anatomy of the lesions, the number of the lesions. Then we have had syntax 2 score that also gave us much information considering the options that we can give to our patients. From syntax first, we have had the information that there were significant difference in cardiovascular death in favors and CABG, and differences were caused by a reduction of MI-related death with CABG compared to PCI. So after 5 years, CABG remained the standard for care for patients with 3-vessel or left main coronary artery disease compared to PCI. We have had several more studies concerning the patients with left main disease that also favored the patients to go to CABG. There were several studies that have studied the non-diabetic patients with multi-vessel disease. As you see that the CABG was favored syntaxes, and at 10 years also favored the CABG procedures. Freedom trial also to our interest was favoring the CABG procedure. Stitch trial that we have seen, it was comparing the medical therapy over CABG procedures and showed that the CABG was better in late outcome versus optimal medical treatment. What do we have now? The FFR guided trials that was trying to figure out what lesions should we treat and what we should not. There were several studies recently. Some of them are the Future, the Flower MI, and FAN3. What did Future trial did tell us? Basically, it was a negative trial. It compared the FFR, this is angiography guided strategy for multivessel coronary artery disease. So the primary endpoint for FFR was 14.6%, and for angiography group was 14.4%. So basically, it didn't give much information. Yet the multiple vessel disease patients were randomly assigned, and the MACE was only at 1 year. The Flower MI, this is the study that compared the patients with ST elevated ST elevation myocardial infarction with multivessel coronary artery disease. The culprit artery angioplasty followed by angiography guided versus FFR guided. So it also was a negative trial. You see that if we magnificate the graph, they can see that there is no much difference indeed. Then we have had FAN3 trial that compared 3-vessel coronary artery disease patients randomized for FFR or without it. The primary endpoints were death, myocardial infarction, stroke, or repeat revascularization. Diabetic patients were 29%, with patients with low ejection fraction below the 50%, and 21% of the patients have had chronic total occlusions on coronary arteries. Syntax score median was 26. The patients were distributed like 33% were the patients that have had syntax score below 22. Intermediate risk patients with syntax score 23-32 were most, they were 49%, and the high risk patients with the syntax score more than 32 were 18%. The MACE based on syntax score was devised like this, that the low risk patients, the angioplasty group was 5.5% versus 8.6%, I mean the MACE. The high and intermediate risk were assigned as follows: 13.7% for PCI group, 6.1% in CABG. And the high-risk patients with the syntax score more than 33 were 12% and 6.6% in CABG group. So total, it was 10.6% in PCI group and 6.9% in the CABG group. So what do we have in conclusion after these novel trials? The FAME3 trial showed us that the CABG has shown better outcomes than revascularization through PCI, and nevertheless of the usage of the FFR guidance. So what do we have in conclusion now? There are plenty of data that FFR is useful for taking decisions in some kind of patients where we do not have an answer from the start. So what should we do now? Sure, we should use FFR in PCI patients, in patients with multivessel coronary artery disease. So it will help us in then making of the decision. These are the comparison about MACE outcomes in FAME3 compared with syntax trial. So we see clearly that the graphs are different now. So what is now in ESC, European Society of Cardiology guidelines? That the clinical characteristics that influence and favors the PCI, the presence of severe comorbidity that are not very good for CABG procedures, advanced age, and reduced life expectancy, restricted mobility, and multivessel disease with syntax score below 22. It favors the PCI. The patients that are diabetic with reduced left ventricular function, less than 35%, and contraindicated for DAPT, dual antiplatelet therapy, should be favored for CABG. These are some infographic data concerning the favors of CABG versus PCI. What are the positions of surgeons? Basically, there were several trials that have shown that CABG is better in the multivessel disease group because of the anatomy, because of physiological aspects of the coronary circulation. Now we have guidelines issued by American College of Cardiology that in many cases favors the CABG revascularization type for multivessel patients. For sure, we should not forget about optimal medical treatment because our patients are not only coronary vessel diseased patients, they have risk factors that should be treated by medical therapy, by diet, by changes of lifestyle, because nevertheless we could revascularize through cabbage or PCI if the patient is still not compliant to medical treatment, or he is not compliant to diet or lifestyle changes. He will have the further revascularization in future. So what to do? For sure, we should have this hard team approach where we discuss surgeons and interventional cardiologists and cardiologists to select the optimal therapy for a patient. What was not mentioned in the phase 3 trial, maybe it should be taken into consideration, that only 11% of the patients were assigned to intravascular imaging. So to conclude, what should we do? Medical therapy is the first choice. Risk factor modifications, as we mentioned. The PCI group will still have the patients that are at high risk for cabbage procedure. So the PCI should be considered in this case. The surgery group still remains very high. So it depends on the anatomy of the lesions, of the length of the lesions, what is more suitable and more physiological in this case. Thank you for your attention.
Thank you, Dr. Kalinici. We are a little out of time, so we will go on. But I want just to comment that really this problem will continue to be active because of continued, of course, improvement in not only diagnostic but also treatment options, devices, techniques. So thank you very much. It was very interesting. We will go on to the next one presentation. Thank you. Dr. Giorgio Romero from Boston, Director of Arrhythmia and Electrophysiology Research and Associate Director of the Ventricular Arrhythmia Program from Birmingham and Women's Hospital, Harvard Medical School. And the theme of the presentation is Update on Ventricular Arrhythmia Therapies, Invasive and Non-Invasive. Dr. Romero.
Hi, everybody. I'm gonna share the conference. Good morning, everybody. My name is Jorge Romero. I work at Brigham and Women's Hospital in Boston, Massachusetts. It's an honor to be here. And I want to thank all the organizers, especially Dr. Sanina, for the kind invitation. Today I'm going to be discussing new therapies or updated therapies for ventricular arrhythmia treatment. So this is something important. This is the CASPER protocol that is being used for over the last 5-6 years to try to diagnose many patients with ventricular tachycardia, ventricular fibrillation that we thought it was idiopathic. So if we do like careful assessment of these patients and we take a minute to look at the EKG, we do even monitors, PET CTs, cardiac MRIs, genetic testing, we're gonna be able to diagnose up to half of this so-called idiopathic ventricular fibrillation. So before I go into the heavy duty stuff, it's important to know that every time we have a patient with ventricular fibrillation or ventricular tachycardia, we need to take a minute to look at the 12-lead electrocardiogram, okay? Because not everybody's gonna benefit from getting a VT ablation or cardiac denervation if we don't really know what's the etiology, okay? So 10 diagnoses that everybody has to keep in mind is, first of all, you have to make sure the patient doesn't have a myocardial infarction or any kind of myocardial ischemia. Make sure the patient doesn't have long QT or short QT, CPVT when bidirectional VT, Brugada syndrome, ARVD with epsilon waves. We need to make sure that we're not dealing with a patient with digoxin toxicity that is also going to give you bidirectional VT, or that is we're having ventricular fibrillation due to PVCs, hypertrophic cardiomyopathy, or early repolarization with elevated J points. So even though I'm going to be showing you like the latest of the latest, I always like to show this study that was published more than 20 years ago. So this is a randomized study showing the impact that sympathetic blockade have in patients having ventricular arrhythmias, okay? So when a patient codes and you know that it was because ventricular tachycardia, ventricular fibrillation, if you give this patient esmolol drip, propanolol, or left sympathetic ganglion blockade, you're gonna see that these patients have a 75 survival versus 4% survival if you just do ACLS measurements to revive these patients. So it's very important, and most of the time people don't even use esmolol drip, and it's a very easy way to control patients with electrical storm. So the studies that we have trying to define what's the best antiarrhythmic to control electrical storm or ventricular arrhythmias there are only a few. So this is the biggest randomized controlled trial published in the New England in 2016, comparing amio-lidocaine and placebo. And as you can see, of course, amiodarone and lidocaine are going to decrease the amount of shocks or VT episodes in those patients. But the primary outcome, that is survival to discharge, it was negative for if you compare amiodarone to placebo, lidocaine to placebo, or amiodarone to lidocaine. So no significant difference. Why am I showing you this? To prove that you're not going to improve survival long-term if you don't do something more aggressive than giving an antiarrhythmics. So we do have two randomized controlled trials comparing procainamide versus lidocaine and procainamide versus amiodarone. And as you can see, when you use procainamide, you break the VT much more often than with lidocaine. And when these patients cross, patients who didn't respond to lidocaine, they're going to respond to procainamide. And this is the famous Procamio randomized controlled trials comparing amiodarone and procainamide, published in 2017. And you can see here that there's a 30% absolute difference in adverse events versus compare procainamide and amiodarone. And more importantly, you have a 30% absolute difference of tachycardia termination when you use procainamide. However, nobody uses it, but everybody keeps using amio. But this is solid evidence that procainamide should be the drug of choice for these patients. You're going to be 3.5 times more successful if you use this medication in the emergency department or in the ICU. For long-term antiarrhythmics, now we know that quinidine, even though it's not available in most countries around the world, it's only available in 22 countries, but it's a great medication to treat either Brugada syndrome or short QT. Also, it's very important medication now, at least in the US, we use it very frequently when we fail a VT ablation. You can see here, either if patient has in electrical storm or not electrical storm, you're gonna control essentially every single patient. And it doesn't matter if it's polymorphic or monomorphic VT, you're gonna have great success with quinidine, especially quinidine gluconate that doesn't really have side effects. Flecainide, now we know that is the drug of choice to treat catecholaminergic polymorphic ventricular tachycardia. You see that all the outcomes are great with this medication. So once we have given medications to these patients, we need to, and if we are unsuccessful, then immediately we need to intubate these patients and give them deep sedation with propofol and ramifentanil. That's what we use here at Brigham with great results as well. Because you need to gain time to see what's going to be the final plan for this patient. So try to give procainamide, try to find the etiology, procainamide, maybe esmolol drip, intubate the patient if it doesn't work. And once you have the patient under control, then you can think about more advanced therapies, okay? So the first thing you have to go do is call electrophysiology or someone who knows how to interrogate an ICD, because most of these patients are going to have ICDs for primary prevention or secondary prevention. So probably 10-15% of all ICD therapies are inappropriate therapies, okay? So it's important to know how to interpret those intracardiac electrograms, because you can be oversensing the P waves. You can double count the R waves. You can oversense the P waves, especially in patients with hypertrophic cardiomyopathy. You can have noise for electromechanical interference when you're close to drills or different devices. You can oversense your diaphragmatic myopotentials, and you can get actually ICD shocks for this, or you can have noise due to lead fractures. This is also important when we program the ICDs. These are results of MARID IRT, showing that if you program the device for delayed therapies, waiting 60 seconds until, if you're in sustained VT more than 60 seconds, then you get therapies. But otherwise, most of these episodes are going to terminate spontaneously. And that reflects, if you do that, you're going to decrease all-cause mortality in patients with ICDs. This is important in the ICU or CCU setting. Some patients got into refractory ventricular fibrillation, refractory ventricular tachycardia. What we do in those cases, after we have failed with medications and intubation, is to start pacing the heart very rapidly, okay? So we pace very rapidly, we shock the patient, and in that second that the patient is in sinus rhythm, we can take control of the rhythm, and then, of course, we're not going to pace the patient at 250 beats per minute, but once we take control of the myocardium, then we can decrease the heart rate until, we go to 90 or 80 beats per minute like here, okay? And this is the example of the prior patient. This patient underwent CABG, and he had diffuse vasospasm. So we stopped the drips, and that was all the treatment the patient needed. So important to know is probably if we work in a tertiary hospital, we should we should know how to do a stellate ganglion block, because it's going to be very helpful and it's very easy to do, So with ultrasound, we just localize the carotid artery, the IJ, and the longus colli muscle. So here is the sympathetic change. We can have an anterior approach or a lateral approach. But if we use the anterior approach, we have to just go through the internal jugular vein, and we put 8 to 10 cc's of bupivacaine, and that's going to give us control of the ventricular arrhythmias probably for 18 to 24 hours. Here, this is an example of a lateral approach going to the sternocleidomastoid muscle. And you can see the needle here going into the anterior fascia of this muscle. And we just put a little bit of bupivacaine, and that's very helpful. And it takes only 5 minutes. Here at the Brigham, we use actually tubes. We leave tubes to have continuous infusion of lidocaine or bupivacaine so we don't have to do VTs in the middle of the night every day. So this is the data of a stellate ganglion block in Duke. You can see that at 24 hours, we have significant reduction of shocks, either for ICD shocks or VT episodes. And at 48 hours, the effect remains pretty much the same. So for ablation now, we just saw this paper published in JACC, the Survive VT trial by a group in Barcelona, Spain. And this is first-line therapy. So they're comparing VT ablation versus antiarrhythmic therapy. And you can see there's also a 20% absolute reduction. So we don't really have to wait until patients fail 1 or 2 antiarrhythmics. Now we know that if we do homogenization, a substrate-based ablation is going to be better than when we used to induce and map that specific VT, because patients have many channels, many isthmuses. So it's less elegant, but more effective, as we can see here in the VISTA trial. There are many techniques to do a substrate-based ablation. You can do scar channeling, core isolation, homogenization, or just ablate the late potentials, but all of them are pretty comparable. We did this meta-analysis, and if you do substrate ablation versus the standard ablation technique, you actually decrease the composite of ventricular arrhythmia recurrence and all-cause mortality. That we published when we at the Brigham. So this is, you have a patient with VT. You have to stratify these patients in 2 groups, okay? So one, you have to decide if the patient have normal heart, no low left ventricular ejection fraction. You know that probably with one procedure, the patient never gonna have VT again, and they're gonna have a great survival. However, when you have ischemic or non-ischemic cardiomyopathy patients, you know that you're going to see those patients more than once, okay? And the mortality at 8 years is not great, even when you do endo-EPVT ablation. So they might need endo-EPVT ablation, cardiac denervation, renal denervation, radiation therapy. I'm going to show you all these things in a few minutes. And this is very important. So the moment that you decide to take the patient to the EP lab or you refer a patient for VT ablation, you need to trust that electrophysiology, because if they don't get the VT during that procedure, the mortality of those patients at 1 year, I mean, you cannot live in VT storm all the time, okay? So if you don't get it, these patients are going to do really bad. So you really need to spend time in the lab trying to get rid of these VTs. So this is also a paper that we published here at the Brigham. So showing that you don't have to wait until the patient fails 1, 2, 3, 4 antiarrhythmic. So the moment that someone fails one antiarrhythmic or no, or you can go directly to VT. Now with new data that I just showed you with the Survive VT trial. But you can see the VA recurrence, the freedom from VT recurrence in ischemic and non-ischemic is different, significant, and mortality. You're gonna affect mortality if you take these patients to the EP lab in a more timely fashion, okay? This is a meta-analysis also comparing early versus late referral for VT. Early can be defined as failing 1 versus 2 antiarrhythmics or having VT ablation in the first month after the first shock or after the first shock. And of course, here you can see if you take the patient early, the acute complications are gonna be probably half if you take the patient in a really bad condition. What can we do to increase our success rate? Most of the time we have to go now endo-epicardial. Of course, getting epicardial access is a little bit risky, but that's why you need to know how to do it. In VT recurrence, major difference. And for the, in EP, there's not too many things that decrease all-cause mortality, but you can see if you do endo-epicardial VT ablation, you're gonna decrease all-cause mortality. It's probably 8% absolute difference, okay? Of course, more adverse events, but it's not significant as long as you know how to get epicardial access. Probably this is one of the few randomized controlled trials in VT ablation. This is in Chagas disease. It's very common now around the world, in the United States, Europe, South America, of course. And you can see the success rate of, when you do endo-epi, you have complete or partial success most of the time versus no success at all with endocardial ablation in Chagas disease. Of course, we couldn't demonstrate mortality because most patients who fail endo during the procedure, they have to cross over to endo-epi, for ethical, points. But the VT recurrence at long term, it was massively different when you go epicardial. We have published also on this several techniques to get epicardial access. We usually use the lateral wall, lateral fluoroscopic view to see the anterior border of the heart, and we do an RV angiogram to define and to try to minimize the risk of inadvertent right ventricular perforation. And we also do a pericardiogram just to make sure the patient doesn't have adhesions and that we're actually in the space that we want to be. Also, we know that if we're gonna take someone for VT ablation, it's ideal that the patient is not on amio, because of course on amio is gonna be a faster procedure. We're not gonna be able to induce the VT, but once we stop the amio, we see massive VT recurrence compared with patients who go to the lab without amio. So probably procainamide is the best option for these patients. We know now that even for Brugada syndrome, we can do epicardial ablation in the RVOT with great results. And you can see the Brugada pattern and how it disappears at 1 month in most patients. So those patients probably don't even need ICDs anymore. This is just to show you that sometimes we have intramural ventricular tachycardias or LV summit ventricular tachycardia that is impossible to eliminate with just one lesion in any part of the heart. Okay, so for those kind of ablation patients, we have developed techniques. Miguel Valderrabano in Houston, Texas, he pioneered the mapping the branches of the coronary sinus with wires. And once you find an early site, you can do alcohol infusion. You can see here, how do you see the myocardium after an ethanol infusion and how he suppresses the tachycardia with alcohol, and it's pretty safe. Okay, the risk of complete heart block, even when you induce this through the septal perforator, is less than 1%. We can also use coil embolization when we work with our neuroradiologist friends. When you have an epicardial substrate and you're close to the coronary arteries, like in this case, we can do an anatomical endocardial ablation, high power, long duration. I'm taking the risk of perforating the myocardium, but if you're careful and you monitor the impedance drop, you can actually terminate VTs that are epicardial VTs, but from the endocardial surface of the heart. This is a technique that we developed at UCLA with Shiv Kumar for also intramural substrate. So we actually cannulate in this patient the LAD, and we use one of the septal perforators. As you can see here, we advance a CTO balloon and we perforate the artery to deliver radiofrequency energy into the muscle. And we transfer the energy from the catheter, the ablation catheter, into the proximal portion of that wire to go into the muscle. So this is an example, the last case that I did when I was at Montefiore. Here is, we have the wire in the first septal perforator, and after 10, 15 seconds, you know how these PVCs are eliminated. And these are the lesions that we create seen by cardiac MRI. Also, bipolar ablation is very useful. You need an active catheter and a passive catheter. You create massive lesions. The problem is that it's very difficult you need to do a homemade connector because it's very difficult to connect two ablation catheters into the same generators, but it's possible. And we published this paper also that given the thickness of this muscle, when you ablate from all three different sides, you can be very successful without any fancy techniques. So cardiac denervation is something that we do like on a weekly basis here. I work in a VT referral center. So many times when we fail VT ablations or patients are not candidates for VT ablation because they're very sick, we send these patients for cardiac denervation. It's a procedure that takes probably 20 minutes in one side, 20 minutes in the other side. And what we try to do is try to eliminate the sympathetic change from the inferior portion of the stellate ganglion to T4. So we know that bilateral denervation is better than left sympathetic denervation, 35% success difference. And it's very good that all cases after you fail VT ablation, your freedom from VT is going to be 60% at 2 years. And more importantly, your survival, once you're in electrical storm and you get cardiac denervation, your survival at 24 months is going to be 70%, which is great. Renal denervation is also an option, but I mean, we don't really have data, massive data in VT ablation. We have data, a lot of data to treat hypertension or atrial fibrillation. And probably the future of VT ablation is going to be radiation therapy. We do it here at the Brigham. So patients who failed VT ablation, endoepicardial, cardiac denervation, renal denervation, they go for radiation therapy, and with great results so far. And of course, we have to, I know I've given you a lot of information, but you have to make a decision in 24, 48 hours whether or not the patient had a good response to VT ablation or to all these therapies. And if they don't, I mean, you cannot keep thinking about it. You just have to decide if you're going to put the patient on LVAD or patient is going to go for heart transplantation. Thank you so much.
Thank you. Thank you very much, Dr. Romero, for this, very clear, very informative lecture regarding the issues and challenges in the problem of ventricular tachycardia treatment. So we need to move. Thank you very much. We need to move. And the next one presentation is from Kristina Sanina, and the theme is invasive management of acute myocardial infarction complicated by cardiogenic shock, types of mechanical support. Kristina.
Good afternoon. Can you see my screen?
Yes. Oh, no.
Yes.
This one.
Can you see my screen? Okay. Okay, thank you so much for having me. My name is Christina Sanina and I work at Montefiore Medical Center, Bronx, New York. And I'm going to talk today about the invasive management of acute myocardial infarction complicated by cardiogenic shock and types of the mechanical circulatory support. I have nothing to disclose. So we're going to discuss several points is the definition of the shock and classification, initial management of shock, left heart cath, right heart cath, echo, revascularization strategies, and types of mechanical support devices and complications which they carry, and of course TCU care. The incidence of cardiogenic shock in the acute myocardial infarction is still high. It's reaching 10%. And the worst thing is that cardiogenic shock is still has high mortality, reaching 45%. Of course, it's a decrease from 1997, 1998, when the mortality was more than 60%. And this decrease is likely related to the growth of primary PCI centers. I want to talk also about the gender difference with acute myocardial infarction and shock, that women actually who present with the myocardial infarction and shock are significantly older than men, and they, on the initial presentation, have their renal function is worse, so they do poorly, they have high mortality. They actually are less likely to undergo diagnostic angiography and PCI on time, and they are less likely to receive mechanical circulatory support. The definition of cardiogenic shock is the one second. Sorry. One second.
Christina?
1 second, please.
Можно вернуть слайд?
I apologize. Yeah, I'm coming back. Of the cardiogenic shock is the more than 30 minutes of systolic blood pressure, less than 90, cardiac index 2.2 liters per minute per meter square, secondary to the cardiac dysfunction, and the requirement of inotropic and vasopressor agents or mechanical circulatory support. Other definition, which is more simple definition, is systolic blood pressure less than 80 despite the vasopressors. And here you can see the SCAI classification of cardiogenic shock, which starts with the A, B, C, D. A and B, A is the patients are at risk for cardiogenic shock. These are the patients which do not experience signs or symptoms of the shock. They do not experience the hyperperfusion or do not even experience the hemodynamic instability. And but these are the patients who may go to shock and with a large anterior myocardial infarction. And as you see here, we also include the physical exam, biochemical markers, which are lactate and creatinine, and elevated LFTs, BNP, and hemodynamics. Here is again the same classification, and A and B stages, these are basically pre-shock stages, and C, D, E, and these are the shock stages. This is more simple approach of the SCAI shock staging. The A, again, no hemodynamic instability, no hyperperfusion. B, hemodynamic instability without hyperperfusion. C, hyperperfusion without deterioration. D, hyperperfusion with deterioration. And E, hyperperfusion with refractory shock. And here, there is another diagram which shows that the number of drugs and the number of devices basically correspond to your stage of the shock. There are risk modifiers which are separate from shock severity, and they influence the mortality. of these patients. This is the older age. The older is the patient, regardless of the shock stage, the mortality is high. The worsening shock, so how fast the shock progressed from one stage to another. The poor hypodynamic monitoring, actually, and lack of the PA catheter use, high array pressure, high heart rate, low MAP, abnormal echogram, and meaning low EF and high E prime, low SVI, and biventricular failure. The other risk modifiers, which are also separate from shock severity and influence the shock stages and survival, cardiac arrest. So no matter what, in what stage patient is presented to the hospital, if the patient had cardiac arrest, his mortality is higher than the patient who didn't have cardiac arrest. And of course, it's reaching the more shock in progress, the more mortality patient has. AKI and organ failure and severe acidosis. This is this hemometabolic shock state, which actually we define this as a hyperperfusion state. Is the state of hemodynamic instability plus its severe acidosis and renal failure. So this hemometabolic shock always has renal failure, and systemic inflammation response also influence the shock, the progression of the shock. Initial management of the cardiogenic shock in the acute MI, the first thing to do is all the viable patients with spontaneous circulation should be brought to the cath lab and undergo PCI as soon as possible. This is what shock trial showed, that early vascularization really saves lives of this patient. Second is we need to define the stage of the shock, and for the stages C to E, its stabilization of the blood pressure needs to be achieved. The MAP of more than 65 needs to be kept. The first line for the treatment is norepinephrine. You can add vasopressin if needed. It works better in the acidosis than other pressors, and it doesn't increase pulmonary arterial pressure. And avoid in initial presentation, when the patient is still not revascularized, milrinone, butamine, and levacimidine, because they worsen myocardial ischemia. Second point is respiratory function. You need to oxygenate. The patient is in cardiogenic shock. They are in metabolic acidosis, or they're going to metabolic acidosis, so they're compensating with the respiratory status. And third is correct acid-base status. Echo is a must thing in cardiogenic shock and acute MI. Emergent echo is needed to define LV, NRV systolic function, valve abnormalities, mechanical complication, pericardial effusion, tamponade, and a left heart cath. Of course, we're doing it to define the culprit artery and treat it. Define the left ventricular EDP. Normal EDP is less than 12, elevated is more than 18, and severely elevated more than 25. In the acute setting, more than 25 EDP is equal to the pulmonary edema. Defining also the coronary perfusion pressure. This is the number you need to keep in mind. The coronary perfusion pressure is your diastolic systemic pressure minus the left ventricular EDP, and normally it's 60 to 80 millimeters. And in cardiogenic shock survivors, it's actually, they do even okay with the 45. If it's less than 45, you're having the ischemia of the myocardium due to coronary perfusion deficit. Right heart cath, we do this to define the central venous pressure, pulmonary wedge pressure, cardiac output, cardiac power, pulmonary arterial pulsatile index. PAPI is very important for right heart failure in the inferior MI. It can predict basically the outcome, and it can guide you what to do with the patient. And the normal PAPI is more than 5.5, the abnormal is less. And of course, mixed venous oxygenation, oxygen saturation, which we see, which we correlate with the organ perfusion. And right heart cath is not required to diagnose shock. I just want to mention this. So revascularization strategies by the SC guidelines from 2017 to 2020, it still remains that we just need to treat culprit vessel in shock patient with acute myocardial infarction, whether it's STEMI or unSTEMI, and basically stage the other vessels. And as you see here, the culprit with the culprit lesion PCI only, it has less mortality than multi-vessel PCI. There is a meta-analysis by Kundu which showed that patients who underwent multi-vessel PCI, they actually has less mortality in the long term compared to the one who underwent only culprit vessel. And but in the same time, these patients who undergo multi-vessel PCI, they develop more renal failure. And of course, culprit shock trial showed that culprit lesion only needs to be treated in the shock. And again, I'm going to repeat myself that stage revascularization of additional lesions needs to be later on. There is the National Cardiogenic Shock Initiative. This is a study which is done in Henry Ford Health System by William O'Neill. And this study evaluates the use of early mechanical support devices in the patient who present with acute myocardial infarction and shock. So patient are treated with, they have a protocol and they have a team, shock team, which when the patient presents with MI and shock, this shock team right away basically assign the device and performs the invasive hemodynamics, and this patient go for the multi-vessel PCI versus single vessel PCI. And here there is a comparison of this multi-vessel PCI versus culprit analysis. And as you see here, the survival actually in multi-vessel PCI in this study is 70% compared to the culprit analysis. And AKI rate is almost the same. So the greater the stage of the mechanical support, the greater the stage of the cardiogenic shock, the more mechanical support you need. And as you see here, that intra-aortic balloon pump is the primary, I guess, mechanical support device, which is used in shock. And as you see here, they in stage A and B, stage B and C, it makes a difference, and a significant difference compared to the stage D and E. It has less support. So going from C and further, these patients may need more complicated, basically, support devices. What we use intra-aortic balloon pump, mostly what we use. And intra-aortic balloon pump is unloading the LV, and it increases the coronary perfusion. Very good for the ischemia, for mitral regurgitation. And we use Impella unloading the LV significantly more than intra-aortic balloon pump. Impella CP, which is 5 liters, and new Impella is 5.5. They basically can support the whole hemodynamics. And of course, ECMO, VA ECMO. This is this goes when the patient has also not only hemodynamic collapse, but respiratory failure as well. And it's primarily unloading the RV. And it's very important to remember that ECMO increases the afterload, which is not a good thing for the ventricle, who is for the ischemic ventricle or just post-MI ventricle. So because of So as once again, that if you have the predominantly LV failure, we use balloon pump, we use impeller and tandem heart. If it's it's a codominant. If it's goes with respiratory failure, it's a VA ECMO. If it's only respiratory failure, it's a VV ECMO. And if it's a right heart failure, it's impeller, RV, Protect Duo, and VA ECMO as well. So once you put the person on ECMO, after the day number 2 or 3, you really need to think how to vent the LV, because the mortality on patients only on ECMO without impeller is actually higher than higher. And what's happening is that because of this increased afterload and your LV has decreased function, you may not have the arterial wave pulsatility, the aortic valve may not even open, and you can have the left ventricular flow tract velocity velocities which are low, and increase if your ventricle is increasing in the diameter, this is the time when you need to put the impeller to vent the LV. Complications of the mechanical support devices. The more sophisticated is your device, the more complications you have, unfortunately. For the aortic balloon pump, renal failure, you see the percentage is the highest percentage of the complication. Actually, it's a renal failure, 16%, limb ischemia, mesenteric ischemia, stroke, bleeding, and all the patients are on anticoagulation. For impeller, hemolysis reaching of 12%, renal failure 18%, bleeding reaching 15%, liver ischemia is 8%. And for ECMO, which is basically your circulatory and respiratory support, is renal failure 55%, bleeding 33%, stroke, sepsis, and limb ischemia. These are like this diagram. It shows all the complications and divides them. Basically, these are all the complications of the mechanical circulatory support. NCCU care, of course, the medication, what we need to give, it's antiplatelet therapy for the patients who underwent the PCI, and there is no need to start the beta blockers or ACE inhibitors or other medications for heart failure in the patients who are in shock or right at post-shock right away. The assessment of the renal function and the early initiation of the renal replacement therapy also plays a role in mortality of this patient. The mechanical circulatory support devices, surveillance and de-escalation. Every day you need to try to win this patient from these devices. And continuous reassessment of hemodynamics and perfusion status. This patient needs to assess daily, and the therapy needs to be according to the results of this assessment. Respiratory status needs to be considered, and mental status. And I just want to say 2 words about the shock teams. It has been shown that actually the centers who have the shock team, and these are the people, it's a critical care cardiologist, advanced heart failure, interventional cardiology, cardiac surgery, and ECMO service. This multidisciplinary evaluation of the patient actually saves lives better than better compared to the hospitals who don't have this team. And because these people overall use more mechanical support device, the time to placement of the mechanical support is faster when you have a shock team. The advanced mechanical support is used more when you have shock team, and advanced is meaning impeller and up. And the mortality, CCU mortality and in hospital mortality is less when you have a shock team on service. Thank you very much.
Thank you, Christina, for this outstanding presentation on such a challenging problem. But we need to move. Thank you. And the last one presentation for this day will be from Miguel Alvarez, and the theme update on advanced cardiac therapies, left ventricular assist devices, and heart transplantation. Dr. Alvarez.
Hello, good morning here in the US. Thank you for inviting me. I don't know if you can see my screen.
Yes. Включите время еще, счетчик времени по докладу. Thank you.
So my idea is to, in the next 15 minutes, provide you with an overview of where heart transplantation and LVAD therapies are in the US today. You know, as most of you know, the heart transplantation dates back to the 1960s when in South Africa, in 1967, the first transplant was done from a 25-year-old woman into a 55-year-old man with end-stage heart failure. This patient lived for 18 days and died of complications from pneumonia. The second transplant survived for 19 months. And then Norman Schumann, who's on the right here, did the first transplant in the US. He pioneered many of the techniques after that. So despite an initial, enthusiasm for heart transplant and 100 heart transplantations performed in 1968, this quickly fell off and only 18 transplants were done in 1970. The problem was not in the surgical technique, but rather in the medical management of these patients, with post-operative immunosuppression being the main problem, and many patients having poor outcomes in the short and medium term due to rejection and infections. So over time, heart transplantation really took off with the improvement in survival that occurred after mainly the introduction of cyclosporin in the mid-1980s. This really changed the landscape because of the effective immunosuppression that was achieved with relatively low side effect profiles. After that, there were more advancements in drugs and clinical care that have, provided us with better median survival. This is the median survival as of 2015, which exceeds 12 years. Currently, there are about 2,500 to 3,000 heart transplants done per year in the United States, but there's over 250,000 people with advanced heart failure who could need heart transplant or advanced therapies. But as you can imagine, the number of transplants is quite limited because the number of donors is limited. And this has been one of the major problems in expanding the number of heart transplants. Before 2018, the allocation system for heart transplant candidates in the United States consisted of a 3-status system that was based on the severity of illness. Because of the donor shortage, there is a great need to allocate organs to the sickest patients in the fairest way possible. So this system was based on the severity of illness and the need for mechanical or pharmacological support. And also patients with complications from LVAD or heart failure therapies were prioritized. So basically, there were 3 statuses. Status A1, which were patients in the ICU with complications from LVAD, or receiving inotropic therapy with a Swan Ganz in place, etc. Status 1B were basically those patients who were at home on LVAD or on inotropes, and status 2 was everyone else. So this was a very, inexact system to really capture the severity of illness in a lot of patients. And so an exception pathway existed where the doctors could send a letter to a committee saying, listen, my patient doesn't fall into any of these high priority categories, but he needs an urgent transplant because of this or that. So from 2006 to 2015, the number of listed candidates tripled, so multiplied times 3, and the number of status 1A candidates multiplied times 5. So people found out ways to make their patients 1A and assumed greater and greater risks to put patients in a 1A status so that they could, provide their patients with the transplants that they needed. But the mortality for 1A candidates was very variable. You would think that an ideal system would put the sickest patients at the highest priority, and so those patients would have the highest mortality. But in that previous system, people with an LVAD infection who would qualify as 1A had a waitlist mortality of 4%, while people on VA ECMO who were on the same tier had a mortality of close to 40%, 10 times higher. So the system needed to be more accurate and more fair to the sickest patients. In October of 2018, during my Advanced Heart Failure Fellowship, there was a change in the allocation system to prioritize the sicker patients, especially those who were receiving temporary LVADs, so like surgically implanted temporary LVADs, Impellas, VA ECMO, and balloon pump, and also to incorporate the most common reasons for exceptions in the prior system. There was also an effort to standardize definitions for cardiogenic shock, refractory ventricular arrhythmias, and LVAD complications so that everybody spoke the same language and cardiogenic shock meant the same to everyone. And also there was an increase in the donor geographical catchment area for the sickest patients. So if you were in a very high priority status, you could now access hearts that were farther and farther away, so that the sickest patients got transplanted earlier. So a 6-tier system was created, and the previous status 1A was broken down into 3 statuses. So status 1 was VA ECMO or non-dischargeable LVAD. Status 2 were the balloon pump patients, Impella, or those with refractory ventricular arrhythmias. And status 3 were those with high-dose inotropes with a SWAN or having LVAD complications. And from there, the statuses went down to a status 6, but these were the main focus of this revised system. So what happened after this was implemented? So after this was implemented, the mortality didn't change, while patients in the highest priority systems got transplanted earlier and quicker. As you see here on the right, the diagnoses that were of the patients that were eligible for transplant didn't change majorly. Still, a similar proportion of patients with ischemic myopathy, non-ischemic cardiomyopathy, etc. So to a certain degree, the new allocation system provided more urgent access to sicker patients with a similar survival at 1 year. So this slide summarizes the changes that we're seeing. So the significant changes occurred in the amount of people that went to transplant with a balloon pump, the amount which grew significantly, as you can see, from the pre-allocation change in blue to the post-allocation change in red, and the amount of patients with durable LVAD, which went down significantly. As you can imagine, if your patient can now get a transplant by having a balloon pump or an Impella, you're most likely to do that and provide them with the best chance of getting a transplant, rather than committing them to a durable LVAD, which then will be harder to obtain a transplant from, because the LVAD status was downgraded in the new allocation system. Other important changes occurred. The waitlist time went down from 93 to 41 days, so decreased significantly because these sicker patients were being transplanted quicker. And the distance traveled increased significantly from 83 nautical miles to 225 nautical miles. So because of this, and one last thing is that here on the right, the number of transplants performed in each region of the United States did not change significantly. This was a matter of concern because obviously there's a greater distance between transplant centers in certain parts of the country versus others. Because of this, the use of the axillary balloon pump became really, really popular. As you can imagine, if you can put a balloon pump through the axillary artery in a patient and they can get up and walk and do rehab while they wait for a transplant, then this is a win-win situation. So this has been popularizing in the United States now, and we published a paper on how to do this safely from the right axillary, which allows for more patients to get it, since a lot of patients have a defibrillator or a pacemaker generator on their left chest. So in this scenario, there is a continued effort to expand the donor pool. So push the boundaries of who we can choose as a donor so that we can have more donors for more patients who need them. The first effort has been in capturing patients who have hepatitis C viremia, meaning patients who have hepatitis C, not only based on the antibodies, but also they actually have circulating virus in their blood. This has come to the forefront now because there is tragically an opioid epidemic in the United States, and more young people have tragically died from opioid overdose. And a lot of these patients are IV drug abusers and are vulnerable to contracting hepatitis C from sharing of needles and stuff like that. The second thing that has, brought this to the front is that we now have access to direct acting antivirals for hepatitis C, and they have over a 98% cure rate, or what we call sustained virologic response. Before 2014, the treatment for hepatitis C was very ineffective, and it had a lot of side effects. So the access to these direct antivirals who we could treat the recipients with is a great breakthrough. And the third thing is the access to the nucleic acid testing. So like I mentioned, these are patients who are viremic with hepatitis C, and we can tell that accurately with this NAT testing rather than just relying on the antibody status. So there's a recent meta-analysis published of all the published experiences of NAT-positive donors in NAT-negative recipients. So this means donors of hepatitis C viremic patients, donors who gave their hearts to people who did not have hepatitis C. The 1-year survival was 93% for all the patients included here. So excellent survival, comparable to the survival of patients who received a heart from donors who were not hepatitis C viremic. However, within 2 weeks, 100% of the people who received this heart became hepatitis C positive, but the antiviral failure rate was only 1.1%. And there were no deaths related to hepatitis C. The hepatitis C donor effort had been abandoned in around the early 2010s because there was dismal outcomes in patients before the advent of these direct antivirals. Now, however, the use of hearts from hepatitis C NAT-positive donors is approaching that of non-hepatitis C donors. So close to 25 to 23% of all the hearts that are offered of NAT-positive donors get used for transplantation, whereas 29% of those with no hepatitis C history are used. So we are coming to a similar usage of hepatitis C positive hearts. And in this study of the UNOS, which is the database that contains all the outcomes of patients transplanted in North America, there was no significant difference in the rates of primary graft failure, which is severe ventricular dysfunction with no rejection, or in the 1-year survival, comparing patients who were receiving hearts from hepatitis C positive donors versus non-hepatitis C donors. Another effort for expanding the donor pool currently is the access to donation after circulatory death. What does this mean? This means that patients who donate their heart, or donors donate their hearts, are not brain dead. They rather experience conventional circulatory death, meaning cardiocirculatory arrest, because they are very sick with shock of different etiologies or from anoxic brain injury, but not brain death, etc. And this has been a pioneering work in the UK and Australia. This was the original method that was used for heart transplants before brain death was legally recognized in the 1970s. However, the barriers to performing donors from circulatory death is not only ethical, but also practical, since the ischemic times will be much longer in these patients. So there are two methods for procuring these organs. One is called the normothermic regional perfusion, in which the patient's body is reperfused with the use of ECMO or different methods, while excluding the cerebral circulation, and then using that reperfused organ in the donor's body to perform different testing to assess for quality, right heart cath, TEE, transthoracic echo. Even the issue is that testing ethically cannot be performed in these donors before they experience circulatory death. So the body needs to be reperfused to perform this testing. Another method is what is called the direct procurement and perfusion, which is, extraction of the organ as soon as circulatory death occurs, and then placing it in an ex situ perfusion, which I'll show you a picture of. Is called an organ care system, also known as a heart in a box. During that ex situ perfusion, the doctors rely solely on lactate levels to assess the quality of the organ. And this is a contested issue that is still evolving. This is a depiction of the practical issues that limit the use of DCD hearts. So as you can see in panel A here, patients who experience brain death undergo heart evaluation during prior to circulatory arrest, and circulatory arrest only occurs after the procurement of the organ is done. So then that organ is placed in what we call cold static storage, which is basically an ice box outside of the body, and is carried to the transplant center and then implanted in the recipient. However, if people undergo withdrawal of care for refractory severe illness or for extremely grim prognosis without brain death, then during the time that cardiocirculatory death or arrest occurs, there is a long time of hypoxemia and decreasing, perfusion of all the organs. After circulatory arrest occurs, there is a mandatory period of standoff when the organs cannot be procured until circulatory death is pronounced. So during this whole time, the organ undergoes warm ischemia within the donor's body before the procurement is realized. If we then put that organ in cold static storage, that prolongs the ischemic time of the organ beyond what is feasible until the time of transplant. So this ischemic time is unacceptable in most cases to perform a transplant. So the ex situ hyperfusion.
I'm sorry, Dr. Alvarez, we are really critically out of time. I'm sorry. Can we just? Okay.
I will end with the DCD explanation. So the ex situ hyperfusion is used to shorten the ischemic time until the organ is transported for transport. So this is what the ex situ perfusion looks like, and it curbs the ischemic time and allows for DCD organ transplantation. So I will end there. These are some of the perspectives of where heart transplant is right now.
Can we conclude?
Yes.
No, but your conclusion, it's very important for your presentation.
Yeah, well, my conclusion is that the future of heart transplant is still evolving. The next frontiers are the expansion of DCD use and the increased use of Hep C donors, as well as xenotransplantation, which is the next frontier in heart transplantation. As you know, a patient was recently transplanted and survived for 2 months. The use of LVADs is changing as a result of the new allocation and the evolving landscape in heart transplant. Most patients implanted with LVAD are now implanted as a destination therapy rather than as a bridge to transplant.
Thank you very much. Me personally, I was waiting for this presentation. I really have some questions because the film, of course, is very challenging and such severe group of patients with advanced heart failure. And so thank you very much. I'm sorry, we are really critically out of time. It was a great pleasure to hear from you. Thank you.
No problem. Thank you.
So, dear colleagues from the audience and dear colleagues from abroad, our lectures, I would like to really thank you for the acceptance of our invitation. Thank you very much for all of us. And thank you especially for the presentation of such outstanding, not presentations, but lectures on the most topical issues in the field of cardiology, cardiovascular surgery, in very severe, very challenging groups of patients, in whom ventricular tachyarrhythmia is treated in ischemic cardiomyopathy, for example, or patients with advanced heart failure, patients with acute myocardial infarction and cardiogenic shock. I hope it was really very interesting session for all our colleagues, and special thanks to my co-chair, Dr. Kristina Sanina, and her great impact on performing this session today. Thank you, Kristina, and please.
Thank you so much for the invitations, and I want to thank again all the speakers. I want to thank Dr. Villablanca. Thank you very much. It was great talk about the valves. Dr. Eugene Kalenic, thank you very much for the PCI for multivessel coronary artery disease. Dr. Miguel Alvarez, thank you for the LVAD and transplant talk, and Dr. Jorge Romero, of course, for the ventricular tachycardia. I think it's very important to have this Science Without Borders, and thank you for your invitation and for this forum.
Thank you again. Thank you all the lecturers for kindly acceptance of our invitation, and hope we'll have further discussion and personally, for example, of the lectures. Thank you very much for all our colleagues. Thank you. Мы закончили.